So I'll speak about the clinical aspects of chronic viral hepatitis, and followed by me, Dr. Shubha will be speaking about the laboratory aspects. So we chose this topic because it's relevant clinically in day-to-day practice for any physician or surgeon or orthopedician, gynecologist, for all specialties. This is of significance. That's why we thought we'll choose this topic for discussion. So I'll start with the patient, which we normally see in our routine clinical practice. So here is a 25 years old male who is a healthy, asymptomatic male who just went to a blood donation camp, and he was found to be HbsAg positive. So he's coming to us and he's in front of us in our OP. He's asking, what should I do now, doctor? So I request the participants to go through the options given below and just make a note of what you will be advising to this patient if he's sitting in front of you today. First is whether you will just reassure him, hey, you are healthy and asymptomatic, you are just 25 years. You should not donate blood, that's all. Otherwise, you are reassured. That is the first option. Second is tell him that he needs further evaluation now. Tell him that he will need evaluation if he is developing any symptoms like jaundice or anything. Or tell him just do liver function test every 6 months, which will tell you whether you are developing any disease. Or whether you will tell you need antiviral therapy, immediately you have to start. Once you confirm, you have to start. So these are the options left out in front of us. So what will be the option that you will suggest for your patient if you see the same patient today evening in your OP? So that you make a note of it. We'll just come back to the same question at the end of the discussion. So if the same patient is HCV antibody positive, what will be your advice? So if it is HbsAg positive or if it is HCV antibody positive, will the response change? Will the advice change? And how will you go about? This is what we want to know. So why do I really want to speak about hepatitis? Based on this patient. This patient is a recently attended patient in our hospital. So he is a 48 years old Mr. X who came to our OP. He's a pre-morbidly well, working as a bank manager. He just came with 1 week history of right upper quadrant pain with nausea. He had an ultrasound taken at local hospital for abdomen pain, which showed a 7 × 7 centimeter mass in the right lobe of the liver with main portal vein thrombosis. Investigation showed that he is HbsAg positive. So this is a tumor marker, alpha fetoprotein, which is 12,000, normal being less than 5. So he is now diagnosed to have hepatitis B related liver disease with HCC, as evidenced by the imaging and alpha fetoprotein, which was later confirmed by higher imaging, a contrast, triple phase contrast CT, which also confirmed the same diagnosis. So the diagnosis is advanced hepatocellular carcinoma. Why it is advanced? Because there is tumor thrombosis of the portal vein. So now at this situation, only palliative care is possible. We cannot do a curative treatment for this patient. So what happened to him? He was subjected to palliative therapy and finally he died within 3 months of diagnosis. Such a pathetic situation. Very healthy, 48 years old, well settled in life, just 1 week symptoms, died within 3 months of diagnosis. Going back to his past history, before going back to past history, I will tell about some facts about HCC. HCC is the second most common cause of cancer-related death worldwide among males. Chronic hepatitis B is the most common cause of hepatocellular carcinoma, and next common cause being chronic hepatitis C. So these two are the viruses which are speaking about today. HCC can even develop in the absence of cirrhosis. I mean, it can even develop in the present in patients with inactive hepatitis carriers. Most of the HCCs are diagnosed in advanced stage like our patient. More than 50% of situations, HCCs are diagnosed in advanced stage where treatment is very difficult and prognosis is very bad. The one important fact that we all need to know is if we give appropriate antiviral therapy, particularly for hepatitis B patients, we can dramatically reduce the risk for HCC. So going back to our patient's past history, 22 years back, now the patient is 48 years old, I told you. 22 years back, he underwent hemorrhoidectomy, and prior to surgery in the preoperative workup, he was incidentally found to be HbsAg positive. So the attending doctor told him, everything is okay, virus is silent, your LFT is normal, nothing will happen, no treatment will eradicate the virus, you have to live with the virus and you are fine. Just undergo hemorrhoidectomy and go home. So this is what his doctor told. He died in 48 years. So what I'm trying to tell here, so what could have happened at 22 years, I'll tell you. The same patient was lucky enough, his doctor would have told, you are carrying a dangerous bug, get evaluated immediately. It may not harm you now, but in future it may harm. Be on regular follow-up. At least yearly viral load testing is needed. If you have high viral load, antiviral therapies are effective to avoid complications like cirrhosis, decompensations, and hepatocellular carcinoma. This is what his doctor would have told if this Mr. X was lucky, and then he will be living happily as a bank manager now. He may live even up to 60, 70, 80 years, who knows? But he died at 48 years. So what I want to insist upon here is incidentally detected HbsAg positive, incidentally detected HCV positive, please do not ignore. So a common clinical scenario, surgeons, orthopedicians, gynecologists, you will often see incidentally detected positivity in a preoperative workup because we all do blood-borne virus screen for all our surgical patients. So we may detect such antibodies being positive. We sometimes get clearance for surgery. We sometimes think LFT is normal, ultrasound shows normal liver, no liver disease, just proceed with the surgery. But we should always remember that we should insist upon the positivity to the patient and insist upon further evaluation, and a possible treatment option should be opened up to the patient and the relatives. Physicians will often see this sort of scenario. They may see patients presenting with full-blown features of cirrhosis, like someone who come in with variceal bleed, someone with ascites, someone with jaundice, or sometimes we see patients coming with just altered LFT. I had a master checkup done, LFT is altered. I was admitted for some other purpose, say I'm admitted for some other upper respiratory infection or urinary tract infection, LFT is incidentally found to be abnormal. So when we evaluate altered LFT, patient may be a carrier of hepatitis B or C. Nowadays, the master checkups are done very frequently in almost all the centers, and people are aware. And we have included HbsAg and Hcv as a part of master checkup, and we find out incidentally detected such patients in masters. So this is a common clinical scenario. So that's why, irrespective of the specialty, everybody will be seeing HbsAg and Hcv positive patients daily. So we should know how to proceed and how to avoid future complications. So it looks like some small cat in front of us that can become a ferocious cat or sometimes even a tiger. So never ignore HbsAg and Hcv being positive in your patients, even if the patient is not symptomatic for the same, and even if the patient has not come to you for the same. So now I'll come to one nice question. So as a physician or as a doctor, if you are forced to get infected with hepatitis B or C, what do you prefer to get, whether it is B or C? Often when we were MBBS students, we were asked whether you want mitral stenosis or mitral regurgitation. So there are very many points, then we'll tell mitral stenosis, I don't want mitral regurgitation. Similarly, if I am forcing you to get B or C, so what will be preferred to get, whether B or C? This question also you keep in mind, you keep your answers in your mind. We'll come to the same question at the end. So this is a third question I'm asking you to keep the answers in your mind. So incidentally detected hepatitis B, what will you advise? Incidentally detected HCV, what will you advise? If you have to get infected, what virus you prefer? So these three questions I have asked you. So as I have been telling, why should we know about chronic hepatitis? They are common cause of cirrhosis, apart from alcohol, obviously. So if you see a patient with cirrhosis, even if the patient is an alcoholic, please do order hepatitis B and C for the patient because they are treatable cause of cirrhosis. So just because patient consumes alcohol and comes with cirrhosis, do not declare the patient as alcoholic cirrhosis. Rather, investigate for B and C because they are treatable cause of cirrhosis. And there is a huge epidemiological burden. We should not think, why should we know about B and C? They are all uncommon viruses. Somebody will see, I need not know about it. There is a huge burden. We are seeing huge number of cases. I'll come to the prevalence of B and C in future slides. Then you will understand the huge epidemiological burden that we have. And also we should know, because it is an occupational threat to us. We may get a needle stick tomorrow from a B positive patient or a C positive patient. What should we do? If we get infected, how to go about? What are the treatment options available? We should know. Not only to us, we may be running a nursing home. We have huge number of staff working under us who may get a needle stick, and we are responsible for treating them too. So for that, we should know about B and C. Then only we can tell worry or don't worry. Iatrogenic spread, as I told you, occupational threat to us. Iatrogenic spread, we may spread to our patients. So today, patients HbsAg negative in the preoperative period. We are operating, for example, you have a uretary calculus, you are doing a removal of the stone and then sending the patient home. Patient is coming back after 2 months with jaundice. Preoperatively HbsAg negative, now HbsAg positive. Patient will tell, from your hospital only I got this infection, treat me. So we should know. So it's an iatrogenic spread. So we have only given the virus from our own instruments. So we should be able to give a proper advice. So for these reasons, we should know about hepatitis B and C. So, and most importantly, that I told through my patients, it's the most common etiology of the dreadful cancer, hepatocellular carcinoma. And an important good point is, lot of advances are there in the treatment over the last 1 decade. So these things insist upon the significance of knowing about hepatitis C for any specialty. So I'll cover these 5 points with regard to both the viruses. What is the epidemiological burden? What is the mode of transmission? What is the natural history? I'll touch upon screening and diagnosis, but I think Dr. Shubha will be covering more on that aspect. And then I'll come to some small, fewer aspects of treatment. So as I said, there is a huge epidemiological burden. You could see that 2 to 3% of world's population are living with hepatitis C infection. More than 350,000 deaths are attributed to hepatitis C each year due to liver cirrhosis or HCC. Sometime back, hepatitis C was the most common indication for doing liver transplant, but now it is fatty liver because of newer advances in treatment for hepatitis C. Hepatitis C is a reasonably manageable virus now. With regard to hepatitis B, it's much more prevalent than hepatitis C. More than 240 million people are having chronic hepatitis B throughout the world, and more than 780,000 people die every year due to acute or chronic consequences of hepatitis B. Coming to Indian data, you can see among general population, the prevalence of anti-HCV antibody is supposedly close to 1%. So that means you go to a busy market, catch some 100 people and do HCV antibody. We may see, for our wonder, we may see one patient out of 100 who are positive for HCV antibody. They may not be actually carrying the virus. Maybe half of them are positive for HCV PCR as well, whereas the rest would have a cleared infection or a false positive antibody. But we may see even 1% of patients who are positive, just simple asymptomatic patients roaming around us may be positive for HCV. Whereas with regard to hepatitis B, the point prevalence is much more higher. It is 3.7% of population. So the same 100 patient, you test both B and C. For our surprise, 2 to 4 patients may be positive for HPSAG, though they are asymptomatic. So 40 million are infected, around 40 million are infected in India, and about 1 lakh die every year due to B-related complications, whether it is cirrhosis or decompensations related to cirrhosis, or it is HCC. So coming to the transmission and prevention. So C modes of transmission, little different. Both are bloodborne viruses, but the most common modes of transmission little different for the viruses. For C, it is mainly unscreened blood and blood products. Even in the modern era, very sophisticated blood banks, still we see blood products as a source of hepatitis C transmission. It's a sad fact, but it is true. Then nitrogenic spread, as we discussed, dialysis, very common. Up to 10% of patients who are being subjected to maintenance hemodialysis are found to be HCV positive in many centers. Even after good universal precautions, that means more precautions are needed. Medical equipment, surgical equipments, glass syringes where needles are not disposed or syringes are not disposed properly. And also IV drug abuse, still India also it is there, but in Western countries, this is the most common mode of transmission. Unsafe piercing and tattooing, we see tattooing everywhere. It's a modern thing that everybody should have a tattoo. Are we doing in a safe center? Are we doing in a proper manner? Are we getting the virus from them? All these things you should think. Vertical spread, yes, of course, not like B or HIV, but little bit hepatitis C also can go for a vertical spread. Very rarely sexual contact. So that's why when we see hepatitis C positive patients, spouses are usually negative, whereas B positive patients, spouses are usually positive. So for B, mother to baby, perinatal transmission, and the most common mode of spread in India is found to be horizontal transmission, which is child to child during play. So younger age from one person to other through contact of body fluids. Unscreened blood transfusions still happen, lesser than HCV, but still there. Unsafe needles and injections like hepatitis C, and also through unprotected sexual contact. So we should also not forget needle stick. We are seeing daily. Needle stick, at least one in our hospital, such a big hospital, we have 4,000 staff. At least one will come daily with the needle stick. With after having instructed so much education, at least one will come with daily. One or the other will come with needle stick. So, what is the rate of transmission of virus by needle stick? We can remember as 0.3330, 0.3% for HIV, 3% for HCV, 30% for hepatitis B. So, hepatitis B is very powerful virus. It can stay back in dried blood sample and easily get spreaded, unlike HIV or HCV. So what is a natural history? So if we have a hepatitis C infection today, so I'll develop an acute hepatitis C infection. So acute hepatitis C is, yesterday I got the needle stick, and after about, or not yesterday, after an incubation period of maybe a month, I may develop infection. So that is acute infection. So acute infections are usually patients develop anictic hepatitis. Bilirubin is not much high, SGOT, SGPT are high, and patient has fever, fatigue, nausea. If it is icteric hepatitis, obviously jaundice also will be there. So such acute infection infections are usually asymptomatic in more than 2/3 of patients. 1/3 of the patients are having symptoms. Why they're asymptomatic? They may have some non-specific symptoms which they may ignore as a routine viral fever. They may not even think it is hepatitis because they do not develop jaundice. So if we have an acute infection, what happens? Only 15 to 25% will clear the virus. So that means most of them will go for chronic infection. That particular acute episode will spontaneously settle, patient will become asymptomatic, LFT will normalize, but patient will continue to carry the virus, and that's the patient becomes a chronic hepatitis C patient. So that means 75 to 85% of the patients will become chronic hepatitis C patients. So they are asymptomatic. If you check the LFT will be almost normal, and patient will be fine and roaming around and doing the routine job and doesn't even know that he continues to carry the virus. What happens if he continues to carry the virus? That is called chronic active hepatitis, and patients 10 to 20% of the patients may develop cirrhosis over a period of 20 years. So see the gap, 20% over 20 years. So it takes a very long time for it to develop into a cirrhosis. So we have a good window gap for us to treat the patient and make the patient free of virus and avoid future complications. So today, if I get a needle stick at 20 years of age, I will be becoming a cirrhotic patient by 40 years of age. So I will develop decompensated cirrhosis by 42, 45 years. I will develop HCC and die by 50 years. That's what happened for our previous patient that I discussed who died at 48 years of age. That was H-base AG. HCV, H-base AG are almost similar natural course. So 10 to 20% can develop cirrhosis over 20 years, and out of which part of patient can become decompensated cirrhosis, and a small proportion can develop HCC. So whereas for hepatitis B, a little different natural history. So I concentrate on adult infection that I am stating here. So if I develop an acute infection today, so after a needle stick or a blood transfusion, generally the incubation period is longer. It can be even up to 6 months. 2 months to 6 months will be the incubation period. And after about 2 to 3 months of getting the infection, I will develop symptoms. So we develop an acute icteric hepatitis. Mostly acute hepatitis B are icteric hepatitis. So they are always symptomatic with nausea, vomiting, jaundice, plus or minus itching. So they will come with a symptomatic hepatitis. The good thing is 95% will clear the virus during an acute hepatitis. Why? The immunity is very good. There is a robust immune response. So there is a good fight between the immune cells and the infected hepatocytes. That's why the patient is symptomatic with icteric hepatitis. And so the virus also will be cleared. So 95, even up to 98% of the patients will clear the virus. Once the LFT settles, HbsAg also will become negative. So they will become normal. Whereas 2 to 5% of the patients can become chronic carriers. So that is, they will become asymptomatic, LFT will become normal, but they will continue to carry the virus. So that is chronic hepatitis. So once they become chronic hepatitis B carrier, so they can automatically become cirrhotic patients in future, which also takes many years, like in hepatitis C, may take 10 to 15 years or 10 to 20 years, depending on the other comorbidities, alcohol abuse, diabetic, and so many other things. The duration may vary, but may even take up to 15 to 20 years for developing cirrhosis. So an adult infection in hepatitis C will result in chronic hepatitis C in more than 2/3 of the patient, whereas it becomes chronic hepatitis B in less than 5% of patients. Whereas coming to childhood infection, as we discussed, childhood infection is the most common mode of spread for hepatitis B. 90% will develop chronic infection. I'll come to why they are developing chronic infection. I'll come to in future slides. Most of them will be asymptomatic. Initial infections are usually happening in immune tolerant phase, like it happens during delivery. During delivery, there is a spread from mother to child, or during the initial years of life, spread from other children or from the family members. So they do not develop much immunity against the virus. So they go for chronic infection. They're usually asymptomatic during the acute phase. So they will be chronically carrying the virus for the rest of the life, and most of them will develop cirrhosis. 40% will develop cirrhosis. Here will develop 50 to 20%. Here 40%. So initial periods are asymptomatic. So that's why when you see a patient who is HbsAg positive, which is incidentally detected in the preoperative workup, if you ask, there will be no past history at all. They will not have any past history of jaundice. They will not even have family history of jaundice. This all happened in childhood infection, and they just carried the virus without much significant symptoms documented in the past. So we will wonder when this patient developed hepatitis B. No, we can't tell when the hepatitis B entered the body, but it is just chronic hepatitis B. That's it. So this patient will develop cirrhosis because carrying since childhood for many years. So many of them will develop cirrhosis as they age. So this slide is little tricky, but it is very nice to understand. This hepatitis B, suppose if I have acquired hepatitis B from my mother during childbirth, so the initial phase is an immune tolerant phase. The body will think, okay, the virus is also a part of the body. I need not produce any antibodies against the virus. So that is called immune tolerant phase. So there will be no immunity because virus also will be considered as a part of our own body because it entered immediately during the birth. So there will be no immunity. So virus will be replicating because there is no opposition. So the viral load will be very high. Envelope antigen is an indicator of viral replication. So envelope antigen will be positive. So there will be no immunity. So antibody will be negative. So there will be no inflammation. So there is no immunity means there is no fight. So there will be no inflammation. If you take a liver biopsy will be almost near normal. And alkaline, ALT, AST, SGOT, SGPT will also be normal. So this is called immune tolerant phase. These patients are asymptomatic and they usually do not have any complication happening immediately. So this is immune tolerant phase. Immune active phase is one. Sometimes body recognizes, oh, I am carrying some virus. I have to act. I cannot be just allowing the virus to replicate and roam around inside the body. So body decides to produce antibodies. This usually happens around 30 years of age, 25, 30 years of age. Till then, patient is immune tolerant during the childhood and adolescence. By 25 to 30 years of age, immunity becomes active, starts producing antibodies. So now there is a fight between the immune cells and the infected hepatocytes. So there is active inflammation in histology. There is elevated SGOT, SGPT. Still, virus is very powerful. No, it has been multiplying over many years. So still, E antigen will be positive, and the viral load starts coming down from lakhs and crores to thousands. So there will be a declining viral load. So this is called immune active phase. Immune active phase is one where the patient is having active hepatitis, abnormal LFT. Some patients may be symptomatic with minimal symptoms like fatigue and weight loss. So these patients, because of inflammation, they can go for fibrosis and cirrhosis in future. So then comes the next phase, which is immune control phase, which we commonly call as the inactive carrier phase. So immune control phase is one where the immunity has taken over the virus. Okay, immunity has become more powerful and it has controlled the virus well. So like to imagine a thief who has been put inside the jail. So now the thief is inside the jail. So he's not active anymore. So virus is controlled well. So the viral load will be very less. So there is no more fight. Virus is controlled. So there is no inflammation. So SGOT, SGPT will be normal. There will be no inflammation in liver histology, and E antigen will be negative. Now the virus is not able to replicate in front of so much powerful immune cells. So this is called immune control phase, otherwise called the inactive carrier phase. So patient will carry the virus, but there will be no hepatitis. So patient is not at risk of cirrhosis. So this is what is commonly seen in routine clinical practice. When we have a patient who comes to us with the incidentally detected hepatitis B positive, most of our patients who are asymptomatic will have normal LFT. They will have very low viral load like 100, 200. If you take an ultrasound, liver will be normal and E antigen will be negative. So we will tell you are having an inactive carrier phase. Actually, it is an immune control phase. And so that patient will be kept on follow-up. Why they have to be kept on follow-up, I'll come to. So immune escape. So such patients, immune control cannot be in immune control phase for many years. Sometimes virus will take over. So the thief will decide to escape from the jail. So what he does, he takes some mutation. He wears some new dress and then escapes from the jail. So virus develops a mutation and it escapes the immune protection. So inflammation is still trying to control the virus. So there will be abnormal LFT. There will be inflammation in the liver. If you take a liver histology, there will be inflammation. But however, E antigen will be still negative because it is mutated, and there will be high viral load. So there will be active fight. So like it happened in the immune active phase, immune escape phase also, there will be active inflammation in the liver, active fight happening. But this is E antigen negative hepatitis. That is E antigen positive hepatitis. So, so here I think it's easy to understand here. The second phase is the E antigen positive hepatitis. The fourth phase is the E antigen negative hepatitis. So both the phases, LFT will be abnormal, not very abnormal like jaundiced patient, little bit abnormal, 50, 60, 70 SGPT also is worrisome. So little bit abnormal LFT, high viral load, here E antigen negative, here E antigen positive. So this is immune tolerant phase, this is immune clearance phase, this is immune control phase, otherwise the inactive carrier phase. This is the immune escape phase or the reactivation phase. So you have 4 phases. Why should we understand these complicated phases? To understand who needs treatment. So you have, as I already told, the 4 phases are again depicted here. Wherever there is hepatitis, there is cirrhosis. So if you have an inflammation, you have fibrosis, and over a period of years, we can develop cirrhosis. And the cirrhosis can go for decompensation and leading to death, or it can go for hepatocellular carcinoma leading to death. So that means whoever is having active hepatitis, either it is E antigen positive hepatitis or E antigen negative hepatitis, should be treated to control the virus so that they do not progress to cirrhosis or decompensation. Whoever is not having active inflammation, either the immune tolerant phase or inactive carrier phase, can be kept on follow without antiviral therapy, because antiviral therapy may not add to the progression of the disease, because already disease is under control. This is what is as per guidelines. But some of the immune tolerant phase also will be treated depending on the viral load, depending on the family history. I'm not going into much detail. This is the broad understanding. So whoever is having inflammation should be treated. Whoever is having inactive carrier state need not be treated, but they have to be kept on follow, because some of them can go to inactive carrier, can see this arrow. Some of them can go for an immune escape phase. Who goes, we don't know. By the time they develop symptoms, they may come with the decompensated cirrhosis. So we don't want that. So we want to be keeping them on close follow and find out who is going for an active phase from an inactive carrier state. So we should keep them on follow. So we have a good set of serological markers in hepatitis B. I think Dr. Shubha will be speaking about these. So as a practical, I'll come to the practical points. So if we have a HbSAg positive patient today, so we'll order these 3 tests. Practically, these 3 tests are actually enough. We need not order a good battery of IgM, anti-HBC, IgG, anti-HBC, anti-HBS. Everything need not be ordered. These 3 gives the clinical information. So you have a patient who is HBe antigen positive, HBe antigen negative. So for a E antigen positive patient, if you have a very high viral load and normal LFT and younger age, that means patient is in immune tolerant phase. For example, somebody who is pregnant coming to you with HbSAg positive, normal LFT, everything is good. Viral load alone is high, E antigen is positive. That means patient doesn't need any therapy unless the viral load is very high, so that it spreads to the child, where you want to give a peripartum period antiviral therapy. Otherwise, you need not treat them. Immune tolerant can also be kept on follow. Whereas if the same patient is high viral load, high ALT, that means there is an active immune response happening, immune active phase. This patient needs treatment. If the same patient is E antigen negative, low viral load, normal LFT, that means our inactive carrier phase. This patient doesn't need treatment. If the same patient is E antigen negative, high viral load, abnormal LFT, treat. So simple understanding, any abnormal LFT, treat. Normal LFT, follow. Simple understanding. High viral load, better treat. Low viral load, keep on follow. So generally the cutoff for low viral load is 2000 international units. So less than 2000, normal LFT, inactive carrier, keep on follow. More than 2000, find out where he falls, which category he falls, and decide on treatment. So the understanding point is, everybody with hepatitis B need not be treated, but at the same time, inactive carrier patients who are told that you need not be treated should be kept on follow to find out what is happening to them in future. So coming to the treatment aspects, what is the treatment goal? We cannot clear the virus. Hepatitis B is a DNA virus, so it is a part of our DNA. It forms a so-called cccDNA. It becomes a part of the host DNA and replicates along with our own hepatocytes. So we cannot clear the virus. So the treatment goal is to suppress the replication of virus, reduce the viral load, so that there is no active immune response and no active hepatic inflammation. Only if there is a liver inflammation, there is fibrosis and cirrhosis. So if you suppress the virus and suppress the inflammation, the progression to cirrhosis can be avoided or at least slowed down. So reducing the viral load will obviously reduce the incidence of HCC, because during multiplication, all these mutations happen and land up in HCC. So if you reduce the viral load, the chance of HCC also will come down. Overall, we'll be improving the long-term survival of the patient. We cannot make the patient HbSAg negative. So that point we should understand. All HbSAg positive patients are positive for lifelong. All chronic hepatitis B patients, not the acute one. Acute one will clear, I told you. All the chronic hepatitis B positive patients are positive for lifelong, except for spontaneous clearance happening in a very small proportion of patients. And at the same time, not all HbSAg positive patients will need medications. Only a subgroup of patients will need medication. So that means your hepatitis B positive patient need further evaluation to find out where he stands, whether he's in inactive carrier phase or an active carrier phase. If he's in inactive carrier phase, tell them to be on follow-up, no treatment. Active carrier phase, start the antiviral therapy. So these are the various antiviral therapy available in market now: tenofovir, entecavir, tenofovir alafenamide, and lamivudine. We choose based upon the patient's and clinical scenario. Commonly used drug is tenofovir and entecavir. So who has to be treated? Again, points are insisted. Immune active phase should be treated. Immune escape phase should be treated. That means active inflammation phase patient should be treated. And those with decommon cirrhosis, already liver is gone. So you want to treat the patient, suppress the virus to avoid further problems and so that they may be fit for transplant in future. Compensated cirrhosis, yes, liver is already damaged. If they have a viral load, you should treat. And one more point is, suppose the patient is going to be on immunosuppression for some purpose. For example, you are an oncologist, you are going to treat the patient with immunosuppression, with chemotherapeutic agents. Even if the viral load is less, even if the patient is in inactive carrier phase, you have to treat the patient, because when you give immunotherapy, when you give chemotherapy, you suppress the immunity, and when the chemotherapy effects goes off and there is an immune reactivation, by the time virus will be replicated and PCR will be high, and patient will land up in hepatitis B reactivation. So whenever patient is on like rheumatologist, like dermatologist who you are using steroids, rheumatologists, dermatologists, oncologists, all these people should keep in mind whenever you are using heavy dose, high dose steroids or immunosuppression, always do check the patient for HbSAg prior to initiation of such long-term immunosuppression, so that you will avoid hepatitis B reactivation at the end of your immunosuppression therapy. Pregnant mothers with very high viral load. This is for obstetricians. Not all pregnant mothers with hepatitis B will need hepatitis B antiviral therapy. Very high viral load, more than 10 power 5. More than 10 power 5 IU per ml will need antiviral therapy to avoid transmission. Otherwise, rest of the patients who are hepatitis B positive with very low viral load, like the inactive carrier mothers, most commonly, they need not be on antiviral therapy. Rather, only the passive and active immunization for the baby immediately after birth is enough to avoid transmission. Again, the same thing. So duration of treatment, when you treat in E antigen negative hepatitis, lifelong treatment, no other option. Patient should be on antiviral therapy lifelong. When you treat E antigen positive patient, we can wait for the patient to spontaneously go into the immune control phase, like that is E antigen negative phase. Then we can give a maintenance therapy for 6 months to 1 year, and then you can stop. So if you start antiviral therapy for a E antigen positive patient, probably we can stop antiviral therapy next few years. Whereas if you start antiviral therapy for a E antigen negative active patient, you have to give lifelong. So for hepatitis C, whenever you have a hepatitis C antibody patient, a positive patient, like the first case that I showed you, incidentally detected hepatitis C antibody positive patient, next test to order is Hcv Rna quantification. So Hcv Rna positive patients are called chronic hepatitis C patient. Hcv Rna negative patients are probably having a false positive Hcv antibody or a past cleared Hcv antibody. So if they are positive for Hcv RNA, then you tell the patient of active hepatitis C infection, and you have to evaluate and treat the patient. So there are 6 genotypes. The genotype determines the treatment and outcome, but however, nowadays we are using pan-genotype medications. Treatment for chronic hepatitis C, goal of treatment in hepatitis C is different from goal of treatment in hepatitis B. B is a DNA virus where you cannot eradicate the virus. C is an RNA virus, you can eradicate the virus. So the treatment goal is to eradicate the virus, make the patient free of virus. So which is called sustained virological response. Like when you treat the patient with anti-HCV therapy, even after 3 to 6 months of completion of therapy, if the patient continues to be PCR negative, then that is called SVR, sustained virological response. That means patient has cleared the virus. So clear the virus so that you reduce the progression of disease to end-stage liver disease or HCC and reduce the liver-related mortality. So the treatment goal is different in B, where you have to suppress the viral load. Here you have to clear the virus. So all HCV antibody positive and PCR positive patient will need treatment, because we can cure the virus. Treatment is easily available, very safe, effective, efficacious treatment, very safe treatment is available. So everybody should be treated. Whereas in the past, maybe before 10 years, we were categorizing the patient, whether the patient to be treated or followed up, because no good treatment was available at the time. So it was only interferon and ribavirin, where the side effects were much more higher than the benefit of clearing the virus. So we were finding out which patient needs treatment. Now everybody who is HCV positive and PCR positive, that means who are all having active hepatitis C infection, irrespective of the viral load, even 2,000 viral load, 20,000 viral load, 2 lakh viral load, everybody will be treated. So everybody should be treated. Hepatitis C is curable. So currently pan-genotypic drug sofosbuvir plus velpatasvir is commonly used. There are other combinations, sofos plus ledipasvir, sofos plus dacletasvir. So many other combinations are available, but commonly used drug is sofos plus velpa, which is very safe and effective. A single tablet, once daily dosage, oral drug, not much of side effects. Usually 3 months, depending on whether underlying cirrhosis is there or what is the genotype, we may have to extend up to 6 months. This is the most commonly used drug with a very good clearance rate of close to 99%. So that means hepatitis C is almost easy to treat, and particularly if you identify the patient in early stage before the cirrhosis develops, it's a very child's play to treat the patient. By the time if you diagnose the patient is already cirrhotic, patient will need treatment for cirrhosis related complications like varicose assessment, ascites, and so on. But however, we can clear the virus even in that group of patients. So the sustained virological response I told you, in long back in 1990, only interferon was available. 10 years back, interferon plus ribavirin was available. Now all oral interferon-free regimen. Interferon is injectable, whereas now all oral interferon-free regimen from 2015 we have this, and this is close to 100% sustained virological response. So you could see the advances in the field of hepatitis C in the past decade. So now coming to the question, so if you are forced to take one virus, whether it is hepatitis B or C, automatically C, because C is curable. So once you diagnose C, you can easily cure and avoid completely be free of disease. So coming back to our patient, so if you have HbsAg positive patient coming to your OP today evening, what will you tell? So you will tell you need further evaluation now, based on which only I can decide whether you need antiviral therapy or not. Definitely you need evaluation and lifelong follow-up. This is what you're going to tell. Not simple LFT, E antigen is needed, DNA is needed, ultrasound is needed, everything is needed. So you cannot just reassure because patient is asymptomatic. You should never tell, come back when you are symptomatic. And you should also not tell you should be on, today I will write tenofovir and give. Not like that. Evaluate, find out whether the patient needs treatment, and then only start the treatment. So if the same thing is Hcv antibody positive, you need evaluation, and probably if you are positive, you are going to be completely benefited by antiviral therapy. So E is the answer. Start him on antiviral drugs after confirmation of active hepatitis C infection. So for the previous question, B is the correct answer. Tell him that needs further evaluation, and based on which only we can decide. We cannot just straight away start antiviral therapy. So take home, incidentally detected hepatitis B needs further evaluation, should not be ignored. Active carriers should be treated. Inactive carriers need not be treated, but should be kept on close follow-up. Incidentally related hepatitis C needs confirmation with Hcv PCR. Once they are confirmed with Hcv PCR, all active hepatitis C patients should be treated because it is curable. Thank you.
The question is how to determine the dosages.
Dose is the same, standard dose. Adults, every adult is on standard dose. Tenofovir means 300 mg once daily, entecavir means 0.5 mg once daily. The dose is the same.
Pre-core mutant and escape mutant.
Pre-core mutant is the one which is E antigen negative hepatitis. What we see the virus in the E antigen negative is pre-core mutant. So where E antigen will be negative, E antibody will be positive because of mutation.
HCV positive patient after treatment, they can, yes, if they can donate blood.
Yeah, once they have achieved sustained virological response and documented to be Hcv PCR negative, that means they have cleared the virus. So automatically they can donate blood. Whereas hepatitis B positive patient can never donate blood.
Most common complication, that's the question.
Cirrhosis. Okay. Over a period of time, they develop cirrhosis.
Final question is again from Harsh. Time interval for LFT monitoring.
So I think you're asking for the inactive hepatitis B patients. So inactive hepatitis B patients who are not on treatment will be kept on 6-monthly LFT and ideally 6-monthly DNA, but practically we are doing yearly DNA. As per guidelines, if you see 6-monthly DNA also. 6-monthly DNA, 6-monthly alpha fetoprotein, 6-monthly ultrasound abdomen, and yearly DNA. This is what we have to do for all inactive carrier patients. Active patients will be on treatment, so need not be closely monitoring them. Once we prove that the drug is working and the primary response is good, yearly once we can follow the patient.
Can NaSH cause carcinoma?
Yeah, definitely yes. Probably in next 10 years, most common cause of carcinoma, hepatocellular carcinoma will become Nash and not GRC, probably, because Nash is now like it is a slow pandemic. It's there everywhere, and Nash has become the most common cause of liver disease and cirrhosis we are seeing nowadays, more than virus and probably it will be more than alcohol also in future. So it can cause carcinoma.
How hepatitis is associated with?
Acute hepatitis can cause cholestasis. Acute hepatitis can have a cholestatic phase. Usually 10% of acute viral hepatitis can go for cholestatic phase, where you will have bilirubin, that's called bilirubinostasis if you see in biopsy. The patient will have itching and high bilirubin, but active inflammation will come down. SGOT, SCPT will all come down. Active inflammation will come down. Such cholestasis usually takes some time to resolve. In current era of COVID, we are seeing a lot of post-COVID cholestasis. B, C cholestasis is less common. C, particularly cholestasis, is very, very rare. B can cause cholestasis in acute hepatitis phase. COVID is causing lot of cholestasis. COVID hepatitis can go for post-COVID cholestasis, which is called post-COVID cholangiopathy. It can also involve the larger ducts apart from intrahepatic cholestasis.
Is there any cutoff value for Hpv Dna low before transplant?
So ideally for any transplant, whether it is liver transplant, any other transplant, we should always have a very well controlled, not detected DNA load, which is very good because we'll avoid reactivation in the immediate post-transplant period or viral related problems. So it's always good to have a negative load at the time of transplant. So if you have a patient who's having a high viral load, by the time we get ready for transplant, treat the patient with antiviral therapy, bring down the viral load and then go for transplant. That will be ideal. Whenever possible, you have to come down to negative viral load and then take the patient for transplant.
What are the starting stage cause hepatitis cancer?
Most of the hepatocellular carcinomas, they present to us clinically in very advanced stage. So they come with liver decompensation as a presentation or sometimes as abdomen pain and weight loss as presentation. If you have to identify them in a very early stage, we have to keep these patients on close follow. That's called surveillance, hepatitis C surveillance. That's what I was telling. Every 6 months, you have to do ultrasound. Every 6 months, you have to do alpha fetoprotein for all HPV positive patients. That means you will identify hepatitis C at a very early stage before the patient develops any symptoms. So that is identifying in the starting stage. In such case, you can easily treat. If there is no underlying cirrhosis, you can go for resection. If there is underlying cirrhosis, you can go for ablative therapies. Or you can even subject the patient to transplant if you identify in very early stage.
Fulminant hepatitis either seen with hepatitis B and C.
Yeah, hepatitis B can cause fulminant hepatic failure, but very rare, less than 1%. Hepatitis C usually doesn't cause fulminant hepatic failure, though it can cause, usually doesn't cause because most of hepatitis C infections are anetric hepatitis, as I told already. Only 1/3 will have ectic hepatitis. So that means fulminant hepatitis is rare with hepatitis C. As you saw in Dr. Shubha's slide, the acute hepatitis profile doesn't include Hcv antibody because Hcv doesn't usually cause acute hepatitis. It generally causes chronic hepatitis. So if you have a clinical suspicion, we should order hepatitis C antibody additionally apart from the acute hepatitis profile. Whereas hepatitis profile includes IgM anti-HBC because there is a window period where HBsAg can be negative, then IgM anti-HBC can be positive, as Dr. Shubha was telling. So HCV doesn't cause acute hepatic failure, acute fulminant hepatic failure usually.
Which guidelines to follow?
Yeah, you have a lot of guidelines. You can follow AASLD guidelines, American Association of Study of Liver Disease, AASLD guidelines you can follow. You have INASL guidelines also, Indian Association of Study of Liver Disease, INASL guidelines are also there. AASLD guideline is an international guideline. We can follow that.
It was a nice session, as we could have seen from the question answer sessions. We have got a lot of questions and all the questions have got really good answers and more. I hope most of the queries has been solved. And even if any of the participant, if they have any future queries with respect to this webinar or any other webinar which has been presented on this platform, they can just mail it. We will forward it to our expert panel, and our expert panel and our presenters or our speakers will answer it by mail. So let me thank the speakers, Dr. Alagammai madam, for accepting this invitation and giving our audience about the insight with respect to the chronic liver hepatitis and also with respect to the laboratory investigations and their usefulness. I am also thankful for all our participants for attending this webinar. And if they have any other queries, they can just forward to the email IDs so that we can forward it to our presenters and expert panel. They will answer the questions. And finally, let me thank to the management of Meenakshi Lab for giving us this platform so that we can share the knowledge from our expert panel and which will reach to most of the clinicians or most of our referring doctors, where they can have the insight with respect to the newer advances in the medical field. So let me thank for all the participants and let me thank to the speakers as well as to the management of Meenakshi Lab. Thank you.